I hope to share some of my experience as a provider with patient care, and that's really kind of the heart of why I'm here. I love education and well, appropriate use and taking care of patients. So if you would ask me 6 years ago, 7 years ago, I'd be here talking about cannabis therapy, I never would have believed you. You know, I never really intended to get into this when I graduated residency and started practice. So as a review, my name is Dr. Matt Mcliff. I practice in St. George Family Medicine with Intermountain Healthcare. I had the Sunset Clinic. And in 2018, when Utah passed that proposition, I had a handful of patients come to me immediately, say, you know, would you write a letter authorizing, I'm already using, maybe some of you have had this similar experience. All throughout 2019, I had several patients come, I'm already using, here's what my condition, would you write a letter and authorize it or condone it or whatever so that I can be covered? Because I'm glad that they passed this proposition. Are we good? That's it. Yeah, thank you. So, yeah, many of you may have had a similar experience, and so I did. You know, like any good family doctor, you adapt to the situation that you're in. You adapt to the population you serve, or the place that you serve, and so I did. And so I worked with them, and I learned more from them about their use and their condition. And then it kept growing, so I decided, well, I better get trained. So I did the Intermountain offering the training program, which was good. In my recertification, I did the Marijuana 411, and I thought that was great. So I'm getting ahead of myself. So there's my introduction. So I grew, the number of patients just kept growing, and I got trained, and I had a very positive experience. And so then I gave a grand rounds to our family medicine providers, our medical group, and explaining how positive my experience was. It was unexpected, but it was a very positive experience. And so some of my leaders liked it, so then I got suggested to serve with the Utah Cannabis Research Review Board, and then that's kind of what propelled me into educating today. Because I think that it's important, especially for primary care, to be educated in this. So there's my introduction. I teach medical students in my clinic, and so I'm passionate about teaching, and I think this is a topic that needs to be taught. So I have 3 objectives with this talk. First is to increase awareness and education about this topic, perception of medical cannabis therapy, because there is a lot of misperception about it, or fear, or just misunderstanding about it. The second would be to achieve a basic understanding of the endocannabinoid system. Again, I'm not a research physiologist. I'm a primary care doctor, but it's worth reviewing the endocannabinoid system because you're not taught in medical school or in any other medical training at this point. It's too, well, you know, the history has been long and sordid, let's say, so it's not part of a regular curriculum. And then the third objective would be to learn about basic dosing and evidence-based guidelines, which the Department of Health tries to focus on. So kind of a list of the philosophy behind this effort is, well, you like it or not, it's here. Like it or not, whatever your past history is or perception is, it's here now and it's here to stay. And as medical providers, whatever your role or your credentials, you should not ignore it. You should become educated and trained. Patients are using it with or without you. And I've often said to people who are unaware, it's not, my experience is not as bad as you think, and it's not as good as you think. You know, there are like anything these days, things can be very polarized. And I really want to help educate and sort of clarify myths or misperceptions about it. It's useful and very appropriate for primary care. You don't need to be an anesthesiologist or a pain specialist. This is really within the scope of primary care. Like Rich had that pie graph of providers. The majority of them are APRNs or nurse practitioners. But the final point is my favorite one. This is one of my favorite, or the most important point of my talk is stewardship. And we talk a lot about that as medical providers, stewardship for antibiotics. We might use that word for opiates and benzodiazepines, but really, this fits right in. We need to be the stewards of this kind of treatment and this kind of medicine. And that's kind of what propelled me into volunteering to teach, because I thought, well, gosh, not only did I have a positive experience, if we don't step up as providers already trained, then somebody else will. And we might not be happy with the way they become stewards of this. So really, I feel an obligation to become stewards of this. So on that note, I want to just talk about 2 patient experiences briefly that illustrate my feeling and my passion about this. The first is a patient of mine. We'll just call his name Tom. It's not his real name, but Tom is a carpenter, and my wife actually hired him to do some work in our house. And he didn't have a primary care provider, so she said, well, why don't you go see my husband? So we set that up. He came to see me. All she had told me is that she told me that he told her that he had a history of drug abuse, but now is sober, and that's about all I knew. So when he comes in, he kind of gave me his life story. Tom, it's a very typical story. He had an injury, spine injury, back, neck, bad injury, bad chronic pain, had to be on opiate therapy for prolonged times. I don't know if he had surgery. I can't remember all the details, but typical story where it changed his life. It wrecked sort of his vision of where he was going. He had now this chronic pain and debility. He got hooked on opiates. Then he got depressed as well, and so he started abusing opiates, and then one thing led to another, got into heroin. Kind of hit rock bottom. But then through treatment, rehab, long time, I'm abbreviating his story, but became sober, started to pick his life back up and improve, and got through all that. And now he's married, has a couple of children, 3 children, has a business, a carpentry business, and he's very successful, sober for a lot of years, and so he's doing great. So he gives me this story, and I'm thinking, gosh, somewhere along the way, he probably used cannabis. I'm just guessing, right? So we're in the office, and I asked him, I said, well, because I asked him, how are you treating your pain now? Are you off opiates? And he said, yeah, I'm clean, and I'm just managing with my pain. And I said, well, did you ever use cannabis therapy for your chronic pain? And his eyes kind of got wide, and he kind of looked at me like, should I say anything about this? I could tell he was nervous, and he paused for this long moment, and then he said, I didn't know I could talk about that here. Right? And I said, oh, that's okay. No, I actually know something about cannabis therapy, and it's very useful for a lot of people with chronic pain, especially getting off of opiates and managing. And he got a little tearful. His eyes kind of watered, and he just said, I'm so happy to get to know you and to be my doctor, because I didn't know that I could talk about that here in this setting. And yes, it's the only way I can function. It's the only way I'm been able to get my life back and be successful with all I'm doing. And it was a really touching moment, but it was one of those moments for me that I thought, gosh, yeah, this is where it needs to happen. This is the place where we need to have these kind of talks. I'm glad that we could overcome that barrier, and it kind of revealed to me there is a barrier. And that's not, we shouldn't have that kind of barrier. If you could, your primary care doctor's office is where you should be able to be honest. So it's been very successful with him, and I've had countless, not countless, but many other situations just like that that's been very, very positive, very rewarding. Now I want to contrast that with a second experience that's different. So I have another patient. Let's call his name Eric. It's not his real name. But Eric, 17-year-old male, started struggling with anxiety, a little depression, but mostly anxiety, having a hard time in school, high school, probably for a couple of years, but I didn't see him during this time. You know how it is. Sometimes you see him for their 7th grade shots, then you don't see him again until they need a sports physical or whatever. So his story was he started struggling with anxiety, and an older friend of his gave him some cannabis, gave him a vape, gave him something. He felt good, it calmed him down. He felt like, oh, this is good. So he started using more, unbeknownst to his family. So this older friend or their family took him to California. They went to a kiosk on a beach and tried to register for a card, got a medical card or something, got some cannabis there and started using more and more. Well, eventually, his mom found out, tried to use the card in Utah. It won't work in Utah. So his mom brought him right in. His mom didn't freak out. His mom knew, I know the family. His mom just said, let's go talk to Dr. Mcliff. Let's do this. Let's have an honest discussion. So they came in, and he tells me this story, and inside I'm kind of cringing. I'm thinking, oh, no, this is not a good idea. I mean, you went to California to a beach kiosk? I mean, how much are they going to care about you, really? And you're using it for anxiety, and it's just not a good idea when you're 17. And so, but we had a really positive discussion about it, and Mom, thank goodness Mom didn't freak out and brought him in, because I tell the story for the same reason. I'm glad that she felt comfortable and knew that this would be a positive, place to talk, a safe place to talk about it. And we did. We had a good discussion. I said, let's not do this for anxiety. I know you felt good, but there are a lot of problems with it, using it the way you're using it. Let's not do this. Let's do something else. And we tried some other things, and we're working with him. But it's not a good idea for a 17-year-old male to be on cannabis for anxiety. No good. Not good. So with that, it sort of illustrates my passion for education, that we want appropriate use. We want to be educated and use it wisely. So a lot of what Rich said, I can skip through some of my slides to get to skip some others, but it's a changing environment. The laws and regulations are constantly in flux. Research and clinical knowledge is surging. I mean, we've had a lot of clinical knowledge, but not enough evidence-based research, so a lot of providers are hesitant to use it. They're hesitant to investigate or to become educated, but that's changing. Public perception is changing. Here's the textbook that I used to kind of reference this talk. This is a really good textbook kind of written for providers, by a provider. It's the same group that does the Marijuana 411, which is one of the 4 approved training modules by the Department of Health in Utah. I liked it. I did my recertification with this program, and I thought it was really good. Here's a timeline. This might be for reference later. I mean, we know that this has been used, cannabis has been used for 1,000 years for medicinal purposes. It's got a really interesting history. It really came to light in Western medicine in 1840. Dr. William O'Shaughnessy in the UK kind of brought it to Western medicine, and they started using it in Britain, and the history is really interesting. What we want to focus on is 1964. That's when THC was finally isolated by a doctor in Israel, Dr. Meshulam, and later CBD. And then, there's a lot of history there. It became Schedule I, despite the Schaefer Commission's urging decriminalization. It was criminalized anyway. So a long history, but what I want to get to is in 1988, this American chemist located a group of receptors in the brain that responded to THC, specifically, right? And so when that was discovered, Dr. O'Shaughnessy in Israel said, well, the brain doesn't make receptors to exogenous plant antigens. There must be an endogenous antigen in order for us to have a receptor to it. So that he reactivated his research and finally discovered anandamide, the endogenous cannabinoid that's analogous to THC, and then later 2-arachidonyl glycerol. That's a mouthful. We just like to call it 2-AG, but that's analogous to CBD. So these are endogenous brain cannabinoids that have a purpose. So then the research into the endocannabinoid system was born. And in fact, there's the timeline. That just brings up to 2020 when we now have a full cannabis program in Utah. So I'm kind of skipping through some of that. Okay, so there are actually kind of about 5 endocannabinoids that have been discovered, but the 2 main ones are those 2, anandamide and 2-AG. What's interesting about them? Well, they're derivatives of unsaturated fatty acids, closely related to omega-3. They're present in cell membranes. They're not stored in vacuoles in the cell. They're actually synthesized on demand in the cell membrane, which is kind of interesting. That's why they're so versatile. So the endocannabinoid system. So what's its purpose? Well, it's a regulator. This is one of the other key points of this talk. Its purpose is to achieve or maintain homeostasis and to some degree neuroprotection. This is key, right? Because we know that cannabis has a myriad of effects with varying degrees of potency. So it's not a specific targeted system for pain or for whatever. It's a broad system that affects lots of different things. So that's why it's a medicine that does a bunch of different things, nothing really, really specific or really potent, but does a lot of things generally well. So that's because its purpose is homeostasis. There are probably more purposes that we have yet to be discovered, but they serve as primary messengers across nerve synapses, but then they also modulate the flow and the regulation of other neurotransmitters. So they keep the nervous system running smoothly. So again, like I said, it's a large and sprawling system. In fact, it's one of the most plentiful receptors in the brain. And that's why it doesn't just target one function, it does a lot of things. So receptor functions, they're the densest receptors in the brain, which is kind of fascinating and often a surprise to many people. There are a lot of these receptors in our nervous system. They relay information about the state of cells, whether you're in a pain state or an energized state or a calm state. It's a very information gathering system. So that has effects in nerve transmission, mood, memory, emotion, pain perception, feeding, reproduction. All of those processes can be affected by this system. So the receptors, CB1 and CB2 receptors, a lot of you may already know. CB1 receptors are primarily in the brain, central nervous system, some glands. They're plentiful in the cortical region, cerebellum, and brainstem, and all of those other places listed there. Also glands, the pituitary, thyroid, and airways, and some of the reproductive organs. CB2 receptors are generally peripheral. Lymphatic and immune system, thymus, tonsils, blood, skin. And so some organs have both receptors, the eyes, the stomach, heart, pancreas, digestive tract. So again, it's kind of hard to make generalizations because they're kind of everywhere. But CB1 receptors, like I said, the primarily central nervous system, the main target of anandamide, and THC, its mimetic compound, 2-AG, and therefore CBD is active at both receptors of CB1 and CB2. That's why CBD is quite useful. CB1 receptors usually affect movement, anxiety, stress, fear, pain, appetite, all those functions that we know. But this activation also can cause psychoactivity, which then can affect short-term memory, cognition, and mood, and emotion, muscle control, pain perception. CB2 receptors, again, found in periphery, blood, and connective tissue. 2-AG and CBD, its primary activator. It can control the release of cytokines, immune regulatory proteins, that can be involved in inflammation. No psychoactivity. Okay, but this is the next interesting part. The attachment's a lock and key paradigm. I don't want to get too much into biochemistry, but it is a lock and key paradigm, but it's complicated. But CB1 has 2 landing sites, right? It has the primary binding site and then the secondary binding site, which has a name, I forgot. But that's where CBD can attach to the secondary binding site and then temper the effects of THC. That's why a combination therapy is very useful. Unopposed THC can be very psychoactive. But balanced with CBD, you can modulate the effect of that THC and reduce its psychoactivity, but still gain a lot of the benefit, especially when the medicinal benefits, through activating CB1 receptors. Right, so CBD becomes a modulator of the THC activity. Okay, but besides the THC and CBD interaction, there are a host of other compounds in the plant, and a lot of patients or users know about the entourage effect. This is when not only with CBD combined with THC, but the other endocannabinoids, which are over 100 that have been isolated in the plant, not to mention terpenes and some other things, all might contribute to this entourage effect. So people who use, they don't know how, but they know that the entourage effect is a thing. It seems to work better when you get a balanced compound. Yeah, so other compounds might contribute to that, but we don't know how much. We don't know exactly. That's why we just label it the entourage effect. We don't know the clinical pathways of the biochemistry yet, but it really is a phenomenon. Another phenomenon that's really interesting is retrograde inhibition. Unlike other receptor systems, the endocannabinoid system can modulate flow of information up and down the chain. Up and downstream. So this can regulate signal transmission, and this is also why it can serve as neuroprotection. This is why it would, for example, help abate a seizure, because you've got a hyperactivity, this excessive neuroactivity in the brain, and cannabis, when introduced, can downregulate that transmission. This is also why users can develop tolerance, though it might serve, though you have tolerance, you can have neuroprotection, and that's why it's not always, well, it's not lethal. Overdose really isn't lethal because it downregulates itself, which is interesting. Which, back to the history, cannabis was often treated like opiates and benzodiazepines. It just assumed that it would cause respiratory suppression and overdose and death, but it really does not. And that's because of this phenomenon. Cannabinoids. There are over 600 chemical compounds in the cannabis plant. 113 cannabinoids or more have been discovered. The major ones are THC and CBD. The plant, when processed, about 40% of it's CBD and about 20 to 30% is THC. Again, it depends on the strain of the plant. So that's about 70%. So the other 30% is a smattering of all these other compounds. The most useful of which are these: CBG, CBN, CBC, and THCV. These are starting to emerge as additional cannabinoids with specific uses. So THC, to review, binds to CB1. It's mimetic to anandamide. It's neuroprotective, analgesic effects. Well, I said that other illicit drugs are neurotoxic, but THC is somewhat neuroprotective. Psychoactivity, it can treat some of these things.
Is it neuroprotective in head injuries as well?
Good question. I don't know.
What was his question?
Pardon?
Repeat the question.
He's asking if it can be neuroprotective in head injury, brain injury. That's a great question, because it might be, especially in a brain that's fully developed. I'll get to later, that's why we don't like it in children, because the brain is developing, and to have downregulation of nerve transmission in a developing plastic brain tissue is not a good idea. You can inhibit development. But in an injury, I don't know, that's another area of interesting research. CBD, cannabidiol, binds primarily to CB2, can be a second binder to CB1, mimetic to 2-AG, 40% of the plant. Not psychoactivity, and mitigates the psychoactivity of THC. That's a very important use of it. It has that calming effect. It can treat anxiety, seizures, inflammation, depression, all of these things that we know. CBG is interesting because it's the third most prevalent, and it has some analgesic effects, not psychoactive, but it also has some, well, antiseptic and antibiotic properties. Probably not useful, but it's interesting. But compared to all the stuff we have, all the antibiotics we have, it's probably not a clinical use. But it has some anti-inflammatory effects. So when combined with THC and CBD, a triple combination tincture is one of my favorite products to recommend because it really adds. A lot of my patients who've used just a one-to-one and then try a one-to-one-to-one THC, CBD, CBG really like it. It just seems to boost more of that pain control. Some lower blood pressure regulation, and who knows about tumor growth. Again, some laboratory findings are interesting, but probably not clinically useful. Like IBDA and IBS, it's promising, but not a lot of data yet to support that. And I talked about the triple combination. That's one of my favorite products to recommend. CBN is very sedating. It's actually not a primary product. It's a breakdown product that occurs later. Has higher affinity to CB2. It's a partial agonist at CB1. But when combined with THC, it's very sedating. So a lot of patients like to use this for sleep. A THC-CBN combination.
Have any of the indications changed on the state level where you're able to write any of these combos? Like, I'm a QOT, and I just barely recertified. I see far more use for anxiety and sleep than I do pain with any of these. And, just in practice, yet it's not indicated.
Yeah, let me talk about that. I'll skip through some of this. Terpenes are the odor-causing chemicals. She was asking about anxiety and insomnia. And so I want to address that in a minute because that's very important. Terpenes might contribute to the entourage effect. They are what give the pungent odor. Who knows what we'll find out with that later. A brief word about 1985 when they approved dronabinol. Many of us may have been familiar with this. Synthetic THC, isolated THC, not useful. It wasn't well tolerated, and it just didn't work very well because again, it was synthetic, didn't have the entourage effect, and it was just THC. It didn't have that balanced effect with CBD and some of the other compounds. So the best thing to come out of that experience was simply the FDA going through all the trials and the testing they had to do to show that the cytochrome P450 system and non-toxicity. That's the best thing that came out of that. Otherwise, these products are not very useful. You're much better off using what we have now than dronabinol. Okay, I'll skip some of this. Whole flower, you can read through this later. I kind of listed advantages and disadvantages. Whole flower is cheap. That's why most of my patients do it. You can get a vaporizer, but it can spoil. It has a pretty good shelf life, but you got to worry about it spoiling and some of the other things about the natural product. Tinctures. Oh well, a brief word about indica and sativa. Yeah. So indica is typically this is the bushier plant that came from Central Asia, kind of more medicinal, more calming. The sativa is kind of more from the Middle East and Africa, warmer climates, so it's a skinnier plant, and it's kind of more activating, kind of more energizing. So a brief word about that. Most plants now are hybrids. People love to talk about the different strains, and they do have some predictability, but it's not really reliable in guessing its effects. So you just got to be aware of that. So that's kind of what they look like. The indica is that bushier one, and the sativa is the skinny one. But of course, the hybrid is the icon that's usually, iconic, shall we say. Okay, vapes. I'll skip some of this. Vapes, because we addressed some of that earlier. Edibles, longer duration. Vapes, faster, shorter. Edibles take longer, last longer. The main thing you got to teach patients, though, is you got to be patient. You don't know if the edible is going to kick in 45 minutes or 2 hours, because it could be either one. And depending on the dose, too. So I've had a couple of patients dose again after 1 hour, and then in 2 hours they were laid out. And a lot of people don't really like the way that feels. Okay, tinctures. I love tinctures because they're safe, they're reliable, they don't look like candy, they look like medicine, they're versatile. I think there are a lot of advantages to tinctures. Topicals can work. Cannabinoids are very large compounds, they're not absorbed really well, so it's got to be in a really good fat-soluble cream to absorb well, but a lot of the pharmacies are doing a good job of making good preparations, so they are worth a try, depending on where the patient's pain is. Patient-centered dosing. This is another one of my key points, and this is why I'm passionate about people getting advice from their medical provider. You know, it's our job to individualize not only the dosing, but their treatment, and if it's indicated, and if it won't interact with any of their other medicines. And it's not simple. A lot of our prescriptions that we prescribe are just dose and frequency, right? If you're doing hydrocodone, well, what's the dose and what's the frequency? That's only 2 variables, but cannabis, you've got dose, frequency, route, THC to CBD ratio, and then if it does matter, the plant derivation. Sometimes it does, sometimes it doesn't. So 5 variables versus 2 variables. So it is complicated. So we need a pharmacist's help, and the patients, I'd rather them come to me to talk about dosing than whatever their friend used, right? So this is another iteration of just tell them to wait. Edibles can be complicated. You want to start, if they're naive to it, start with 2.5 or 5 milligrams, and then work up from there. Most of my patients who are naive to cannabis will settle out at 5 or 10 milligrams, and that's all they need of the THC. CBD, you can use more, but usually, like I say, I like that 1-to-1 ratio, so then the milligrams are roughly equal. Absorption is enhanced by fat, lipids. So that's why a lot of those preparations, like you mentioned, chocolate, you want it in that butter or something that can help you absorb it well. Okay, so this is one of my complaints to the Utah program. They named things chemotype 1, 2, and 3. Chemotype 1 is a THC predominant. I think we should just say THC predominant ratio. Chemotype 2 is a balanced ratio, and chemotype 3 is a CBD predominant ratio. Like I said before, I'm kind of a fan of more of a balanced ratio. I think that's the most useful medicinally, and to minimize side effects. If you have a THC predominant product, certain conditions might benefit from that, but most of the time you're not going to get a whole lot of more benefit by increasing that THC ratio, and then you just increase your likelihood of psychoactivity or side effects. So separated, so this is again, the guidelines on the Utah Department of Health website, and that's been researched is dosing them separately. So yeah, THC, you want to stick to 2.5, 5, 10 milligrams, work your way up. CBD, you can start at 5, 10, or 15. You can start with a lot more. But then you have to buy them separately. And a lot of the products aren't that easy to buy separately, as we talked about earlier. So I kind of just stick with the balanced ratio and work with that. Side effects, we've talked a little bit about that, but fatigue. So getting back to anxiety, THC at lower doses can soothe anxiety, but at higher doses it will trigger it, cause it. So you have to be that's one of the reasons why I think anxiety isn't approved. That's probably the main reason. It's kind of a Pandora's box. Anxiety is hard to measure. It's hard to meter dosing and treatment, and then you have the risk of overusing and then triggering anxiety and psychosis. There are some cardiac effects, tachycardia, drop in blood pressure, dizziness, of course the memory issues. All of these are side effects, mostly from the THC.
Quick question, are there conducting defects too, or effects conduction,
Conduct,
heart.
heart conduction?
Issues with the THC,
yes. Yeah, so,
but there's no receptors there.
right, so it's like, it's got to be indirect. And again, I'm no pathophysiologist. But you're right, so I kind of skipped over that one part. There are no receptors, cannabinoid receptors in the brainstem that causes the respiratory drive. That's why when you overdose, as was previously assumed, right? They assumed that cannabis would suppress respiratory drive like benzos and opiates, but it does not, because there are no receptors in that area. And so, again, a lot of this, we need to understand how this works so that we can use it safely. But you do worry about people with heart conditions to trigger tachycardia or a change in blood pressure, especially with high doses of THC. So that's why, again, I'm always a proponent of a balanced dosing. The biphasic effect is, like I said, at low doses it does one thing, at higher doses it does the opposite. This can be especially true with THC and anxiety, also with muscle spasm and MS. It's very good for muscle spasm and MS, but at higher doses it might reverse on you. Short-term memory. I'm trying to skip through some of this because I'd like to get some more discussion and questions. I'm trying to go a little bit faster. Again, from the 80s, one of the benefits is they tested not a lot of drug-drug interactions, which is good. It might affect the cytochrome P450 system, but not a lot. Lower blood pressure, escalate heart rate, increase sedation. When mixed with other sedatives, can increase the cardiac effects of, well, other drugs, amphetamines especially, antidepressants, beta blockers. And of course, well, as we know, everything interacts with warfarin and the INR. Contraindications, pregnancy, lactation, some cardiac conditions, allergies, of course, and psychosis, and immunocompromise. We don't know how much, right? Immunosuppression could occur with THC, but it's something to think about. Children and youth, I talked about brain development. That's what we really worry about. We worry about teenagers. As cannabis use becomes more prevalent, we worry about teenagers because they're the most impulsive. They're the most willing to experiment. But they also have the most to lose. And so that's why, again, we need to take some ownership and try to use this appropriately and try to restrict and educate use in those that would be harmed, especially children. Cannabis hyperemesis syndrome. So in response to that question, I'll just tell you last week I had a patient, family, husband and wife, they just have their newborn child. He comes in, the father finally establishes care and said, hey, I was just in the ER last week, I have cannabis-induced hyperemesis syndrome. He's been using cannabis for anxiety for the last 6, 7, or 8 years, but now he can't anymore because he kept using. That's, again, I think anxiety is a Pandora's box. It's a slippery slope. They start using it for anxiety, and they start using it more and more and more, and now he's got this hyperemesis syndrome, and now he's got to get off of it. And it's just, I just don't think they're ever going to approve it for that because it's just too complicated. Even though in the certain situations, certain doses, yeah, you can treat anxiety, but it's too hard to regulate that and use it for long-term or preventative therapy.
It's been on the street and people have been doing their own using for so many years that they come to you and
Yeah.
tell you what they've done for the last 5 to 10 years and what works for them. And so saying that we can modulate that, not so much.
It's a hard sell, isn't it?
They're going to reclassify it so it can be researched, whole nother.
I agree. I hear you. That's why I told that story. It's like, well, damage is already done. And if they do reschedule it, then we're going to see, yeah, like you said, we're going to see a lot more use. But I would trust everyone in this room more than those who aren't in this room. So that's why I think we need to be involved. Here's a really interesting slide. I love this one. Neil Benowitz is a researcher in San Francisco. Has a lot of good research on substance use. He did a really interesting study where he compared all of these drugs of abuse, but he separated the results, the outcomes. He divided them into dependence, withdrawal, tolerance, reinforcement, and intoxication. And I like this because I want to get this specific. When people are using these substances, well, what are we talking about? And you'll notice, of course, nicotine, high dependence, not as high withdrawal as alcohol, but high tolerance. But look over there at caffeine and marijuana. Yes, there's a lot of intoxication with marijuana, but as far as dependence and withdrawal, pretty low. And we kind of know this. Reinforcement, yes, people can abuse this. It gets, they have that reinforcement, but not compared to a lot of these other substances. So this slide was really revealing, and when we start comparing substance abuse. Patient selection, again, this is probably one of my favorite points. It's up to us to determine who would benefit from treatment, how they would benefit, how to do it. These are some things that I listed that are relevant when you're talking to a patient and about cannabis therapy. Do they have a condition? What's their age? What's their experience? What's their experience with other controlled substances, with medicine and dosing in general? Their mindset, fears, or an unhealthy attachment. It could be either one. Realistic expectations, setting goals of therapy. That's a list that I think, I hope we would think about this when we're educating and treating patients. Good follow-up and good communication are key. We already went through this with the previous presentation. There's the website. The Cannabis Research Review Board reviews research nationally, tries to synthesize it, process it, and put it in an evidence-based guideline. And here are the links for the qualifying conditions. So we rate the evidence. Is it not enough evidence to recommend? Limited? Is it substantial? Is it high? So that we have all of that information for providers to check out. Moderate evidence for pain, substantial evidence for MS, autism and dementia, not a lot. Inflammatory bowel disease, not a lot. For pain control, yes. For anti-inflammatory product or treatment, no, not very much. Epilepsy, this shows kind of the challenge with studying this. One of the major studies showed 80% reduction in seizures, but then 13% of the patients studied reported an increase in frequency. So then they stopped the study. So they didn't publish the results because they had to stop the study based on their exit, their abort guidelines, right? So what do we do with that? We know that it helps a lot of people, but it could harm some. So I think, again, that's where we are involved to try to help patients navigate this difficult lack of evidence, but yet still being used. PTSD, again, not a lot of data, a lot of use for it. It was the second most commonly used condition in Utah. But true evidence base is lacking, but we know there must be some benefit. There's a lot of people are benefiting. There's the dosing protocol that I mentioned earlier. Here's the reference that we took that from. To summarize, I'm really passionate about stewardship, as you've heard me reiterate several times. The endocannabinoid system is all about homeostasis. And then patient selection and tailoring therapy to their individual needs, I think, is the most important. So we can rely on the pharmacists at the cannabis pharmacies, and they're great. I've relied on them a lot, but I do like to initiate this discussion at least and give a lot of dosing instructions, especially if they're naive to it. Okay, the QMP and LMP program were already discussed. So I wanted to go back to that issue of insomnia and anxiety. So we recently, as part of the Research Review Board, we took on insomnia. So we did a systematic review with the University of Utah researchers. We did a systematic review to try to find evidence with insomnia. And I will agree with with you that most of my patients that use it, their biggest benefit when they have chronic pain is they sleep better. They come back and say, I ask them, how was your experience? And they say, well, I'm doing better. I still have pain, but I can manage it. I can deal with it. I can cope with it. I can get by. Every iteration of that phrase is what they say. And I'm sleeping better. Every single one. So I think when they did the studies, our research, that we had to distinguish between primary and secondary insomnia. Because this is what we're talking about, is secondary insomnia. And patients are benefiting, but when they did the research review, they focused on primary insomnia. And it didn't show a lot of benefit compared, above placebo or above their control. And so that was a little disappointing, but I think it kind of speaks to how difficult this is in the endocannabinoid system, how it's not a precise system, it's a sprawling general system. So I think secondary insomnia, yeah, that's probably its best benefit. But they didn't write that into the law. The law doesn't say, the qualifying medical condition doesn't say primary or secondary insomnia. It just says insomnia. So it's up to us to kind of educate patients the difference. And I think primary insomnia is probably overdiagnosed. I think a lot of insomnia is probably more secondary.
Did you say that is in the qualifying condition?
It's not.
Oh, okay.
That's why
I misunderstood you. I'm like, no, sleep isn't in there.
it's not a qualifying condition in the state of Utah, but secondary insomnia is probably my most frequently reported benefit. But their indication was persistent pain or muscle spasms or whatever we're using it for. So that's what's on the chart. But they have a secondary benefit of sleeping better. And those of you who are prescribing it probably have had a similar experience.
So do you see a difference in age? Because most of my older patients, they try it and then they stop using it.
Okay.
So is there an age group that it seems to do better with?
So the question is there an age group that this seems to work better for? I don't know. I mean, he put up the slide that showed the demographic, and I think was the largest one 30 to 40 or 40 to 50, something like that? I don't know. I practice in St. George, and I have a large older patient population. And so I've had mixed results, but I've had a lot of good results because you've got the patient who's over 65, has arthritis and GERD, or kidney disease, so you don't want to use NSAIDs. They don't want opiates. They've either had a bad experience or they don't function well on opiates. I don't know. I've had a lot of experience with cannabis for arthritis in some of those patients because I'm limited on the other medicines. So, but back to age, again, I'm really scared of increased use in teenagers and even 20-year-olds. In my personal experience, over 30 is I don't hesitate because they, you know what it means when you're 30 years old. You have more life experience, and by then you have more, and they don't really want to get high. They're more developed, and they don't really want to get. They want to get back to their life. They want to get back to their job and their kids. Teenagers and 20-year-olds, well, they think it's funny to get high. 30-year-olds and up don't. They often tell me, I hated it. Hated taking too much. Never want to do that again. So anyway, there were more questions.
I was interested in fall risk, or kind of how do you have that discussion with your older patients?
Fall
about-
risk?
Yeah. things like
Yeah.
that. Is it a beer?
Yeah.
It's not on the beers list, I don't think, but where would it fall compared to other things?
Well, I don't know where it would rank or fall, but I think that's a great point. When I put that list, I didn't spend a lot of time on it, but I tried to make that list of what to talk about with patient selection. And maybe we should put that on there because, the older we would get, the more likely you're going to talk about fall risk. And so I think that should be discussed with that right patient.
Medicine has a history in the past, a lot of treatments that worked, and when some really good hard science was done, it was found out they really don't. Nowadays, that generally doesn't happen as much because there are so many hoops that a new drug has to jump through to get proven both safe and effective. I guess one of my concerns with medical cannabis still is, there were a lot of things you said, well, there seems to be evidence there that sort of is the lack of really good, hard evidence. There's a lot of anecdotal evidence, and we know how anecdotal evidence can be accurate and it can be totally wrong. So what do you say about that?
Well, that's a great question. Thank you, because I think that's the crux of the matter, right? And that's why we have this research review board, because cannabis is unlike any other drug with that sort of bypass. It's backwards. Like I say, most drugs go through a stringent process, design, testing, and by the time we get it, we have some really good evidence. This one's, because of its history, it sort of bypassed that. Now we're using way before we have a lot of experience or evidence, at least conventional evidence. Having said that, though, one of the reasons why I'm here is to try to dispel that a little bit and say, well, you can't hide behind that too much for too longer because we've got more and more evidence. Like I say, we have all that evidence that we've posted on the website. Yeah, it's of limited or moderate nature, but think about it. Can we ever get high quality evidence? Can we ever get high quality evidence in a double-blinded, placebo-controlled trial on something that's cultivated, broad spectrum in the endocannabinoid system? And are you really going to have a placebo? Those who are taking it, are they really going to know or not know? Right? We're not going to get great evidence. So I'm challenging that a little bit and say we've got some and more is coming. But we're going to have to live in a world and be prescribers in a world where it's already here. So hiding behind no evidence, no good anymore. That's what I'm challenging.
My favorite article on that is The Half-Life of the Truth. It's 40 years.
40 years? That's interesting. I like it.
Another comment on why cannabis doesn't work well on PTSD. It's say 90% of the people I see that have a diagnosis of PTSD don't meet anything near the minimum requirements. It's misdiagnosed. So of course it doesn't work.
I agree, right? So that's back to research. We don't get high quality research because we have misdiagnosis. We have ulterior motives, maybe. So that's garbage in, garbage out, right? So,
Or money.
or money, right? So it's hard. It's hard, and that's why I think we need to be educated to the point where we can navigate this world fraught with either lack of evidence, lack of knowledge, or misinformation, whatever it is. It's out there being used. We need to do our best. And that's what I feel like every day as a primary care provider. Well, I'm doing my best. I'm not a specialist in everything, but I see everything, right? And so you get used to practicing the best you can.
You've done a great job today. I really appreciate it. I just finished a 5-hour UU, human default, and you've added some really good information to that as well. One thing, along with your broad spectrum of all the things that you're dealing with as far as the compounds and the different facets of the drug itself that we don't even know about, all the different constituents, you're working with something that we're trying to legalize and either use medicinally, but every state around us except Idaho, they're using it recreationally.
Yeah.
Look at Colorado's law. They're having so much trouble with impaired driving with
Yeah.
marijuana. So
Oh.
there's so many other things that come into this mix.
That's also things we review with the Department of Health. Is we have a traffic and safety representatives, and our impaired driving has gone up. So anyway, thank you guys for listening. I think our time is up, so I didn't want to take too much.
Just one thing. I don't care about statistics. I had incapacity, back and leg pain for months. I tried everything but narcotics. It was down in narcotics. And I started taking cannabis, CBD. I've been free of that thing for over 2 years now.
I'm glad you had a positive experience. Okay, thank you all.